All right. Good evening, Dr. King. As you know, my name is Sam Cox, and I'm doing my presentation on the glenoid labrum repair, specifically a surgically repaired labrum and its rehab process. As you know, I did my internship. There we go. My internship at a uh, physical therapy clinic here in town, Memphis Physical Therapy. Um, During my time there, we didn't necessarily see a ton of labrum repairs. We saw a couple um, rotator cuff repairs, but I actually had this surgery done back in 2014, so it really kind of interested me and kind of to find out what exactly I had done to my shoulder. Um, and I spent a lot of my time there talking with Dr. Teresa McDaniel about specifically this surgery, and um, she answered a lot of my questions, and it made me kind of want to dig a little bit deeper into kind of find out what exactly I did. So that's why I did my presentation on the glenoid labrum. So let's go ahead and start. So what I'm going to do here is I'm actually going to just go ahead and answer all these questions here. Uh, so what exactly is the glenoid labrum? How is it most commonly injured? And the signs. What are the most common signs and symptoms for a torn labrum? As well as how can you actually diagnose a labral tear, and what are the possible treatment options for a labral tear? And you know, well, I mean, back to treatment options. Surgery is not the only option. There's multiple options out there, and we almost only really hear about surgery, but there's other options out there. Um, but for those that do have to have surgery, we're also going to talk about uh, the rehab process and kind of what it entails. So, what exactly is the glenoid labrum? So, the labrum is it's easily described as like a soft tissue that deepens the socket of the glenoid fossa. So, the glenoid fossa is right here. It is the socket in the ball and socket joint, and the glenoid fossa is so shallow that the humeral head doesn't actually fit in the socket. So the labrum is there to kind of deepen the socket so that it fits in there a little bit easier. So you can kind of see in this picture here how it kind of circles the glenoid fossa. Um, I mean, the labrum is not alone in that job. The it's also uh, the humeral head's also held in there by the rotator cuff muscles. Infraspinatus, supraspinatus, teres minor, and subscapularis. All of those kind of work in harmony to stabilize the humeral head. Um, but for the purpose of this PowerPoint, we're just kind of talking about the labrum. So the labrum's main job is to stabilize the head inside of the glenoid fossa. Um, right here, you can kind of see an image that kind of shows a little bit better how shallow the glenoid fossa really is, and how much the humeral head is not in the glenoid fossa. You can also kind of see the tear that I had. I had the slap tear. That's what I had. You can see right here that tendon coming down right there. That's actually not any, it's attached to the labrum, but it's not the labrum. It's the bicep tendon. Um, that's a very common area for a tear to occur. Uh, but yeah, so this slide is actually, we're more so talking about the injury itself, how it can be injured. It's done with like repetitive overhead motions, such as throwing. That was what I had done. Um, Me being a baseball player, it was a bunch of overhead motions, constant, and I never really got a rest from it. And for me, that was enough to tear my labrum. Um, Also, it could be like violent overhead motions, such as a weightlifter. If you're doing an overhead press and your arm externally rotates too much and it just kind of gives out on you or something, or you dislocate your shoulder from it, it could tear the labrum. Um, Also, falling or receiving a direct blow to the joint. Maybe you're a quarterback and you're in the middle of throwing, so your arm is abducted and externally rotated, and you get a direct blow to the to like your chest or to under your armpit, and you're getting tackled, and it one, it could dislocate your shoulder or be enough to tear your labrum. It doesn't even have to be sports related though. It could be you're taking your dog on a walk and you get a sudden and abrupt movement where your dog takes off running after a squirrel, and all of a sudden your arm is going in a motion that you weren't expecting it to go into, and it could, one, very well dislocate, or again just be enough to tear the labrum. So again, it doesn't have to be sports related. Uh, so how to know if your labrum is torn? Well, there's a lot of signs and symptoms for torn labrum. The These are kind of the more common ones that we have. Pain while performing overhead activities, such as throwing. Every time I would throw, I get a sharp pain in my shoulder. It's like a sharp and stabbing pain, like sharp shooting. Um, Also, you get loss of active range of motion, so you can't perform the motion that you usually could. You say you can't. You can usually uh, abduct past 90 degrees, and now all of a sudden you can't get to 90 degrees with your abduction, and that's loss of active range of motion. Um, excuse me. You could also decrease in strength. So your rotator cuffs, say you can't, or you've lost strength in your internal and external rotation of the shoulder. You've lost strength. You also could feel shoulder instability. Last slide I was talking a lot about how your shoulder could dislocate. Dislocating in itself is instability of the shoulder. It's not stable in the shoulder. It's a very extreme instability, but it's instability. The humeral head is not in the glenoid fossa like it should be. Again, like I said, this is not all the symptoms, and this is just some of the more common ones. So here, tests done to diagnose the labral tear. How could you know if you have a labral tear? Well, first off, you need to go to the doctor, and the doctor, probably first thing they're going to do is give you an X-ray, and you're not going to see anything about the labrum in an X-ray, so it's not going to do much. But they'll do a range of motion testing on you, and like in this image here, they're going to test your range of motion with this goniometer here. And right here in this image, they're testing a young boy with external rotation. And then if they feel like it's a possible labral tear or something else, they'll do imaging, some more imaging, a CT scan, MRI, and then they'll also do a clunk test or a jerk test. I've got some videos here that kind of represent or better explain the tests.
Hello, this next test is called the clunk test. This is to assess if there is a labral injury. What you do is you take the patient, bring them into external rotation of the arm, basically in a pitcher's position. Place your hand posterior to the humeral head and drive it forward. This will cause a clunk, and that could be a sign of a labral tear.
And then the jerk test.
In this video, I'm going to show you.
Go ahead and jump forward here. Right here.
Perform the jerk test, have your patient in sitting position and position yourself behind. While you stabilize the scapula with one hand, hold your patient's affected arm at 90 degrees of abduction and internal rotation. Then apply a longitudinal force through the humerus at the elbow and move the arm into horizontal adduction. A positive test is indicated by a sudden clunk as the humeral head slides off the back of the glenoid. In a painful jerk test, this is concurrent with abrupt pain. A second clunk might be observed when the arm is brought back into the original position and the humeral head returns to the glenoid.
All right, and like I said with the other slides, this is not all the tests that are done. there are multiple tests that can be done, just depending on your surgeon and your physical therapist that how they want to go about it. All right, so treatment options. Like I said earlier, surgery is not the only option. Um, depending on your surgeon or depending on how uh, severe that tear is, rest could help for somebody. Letting that arm be immobilized for 4 to 6 weeks and keeping it from moving could be enough to let that labrum heal. Also, physical therapy. Um, Physical therapy for the time being, it could be very helpful in taking the load off of the labrum and letting the rotator cuff muscles take over and kind of take some pressure off of the labrum. And for some, that helps. For me personally, I went to physical therapy for I want to say it was like a month, and then my surgeon felt it was necessary for me to move on to surgery. So surgery for me, that was my option. But again, it's a last resort. You're gonna do things to try and fix it before you have to have surgery because you don't want to have surgery if you don't have to have surgery. Here is just kind of a cool little slides about my actual surgery. Here we've got three images, or we got four images. We got three anchors. I have four anchors in my shoulder currently, and here are three of them. I just thought it was kind of cool to kind of show what it actually looks like, what they're actually doing in the shoulder. Um, and then, so the rehab. The rehab process usually takes around 22 weeks. And again, it may be longer for athletes. The rehab consists of 5 phases, each one building off the last. They're not going to let you move on if you're not ready to move on. If you haven't completed phase 2, they're not going to put you in phase 3. They've got to protect that shoulder and make sure you're ready to move on. And then, like I said, athletes may be longer. For athletes, other things may be added, such as a throwing program or a swimming program or relearning how to shoot a free throw or something. It's all sports. Um, it all just depends on what sport you're going back into. For me personally, it was throwing because I was a baseball player. Here is a video from my throwing program. Just kind of showing what I had to go through. This is relatively short into my throwing program. I want to say this is like a little bit less than 60 feet because the pitcher is not on the mound by about like 54 feet. But this is like as far as I can throw. You see there, I barely made it in. All right, so phase 1. It's gonna start roughly around about 4 weeks after the surgery. This phase 1 is gonna last 4 to 6 weeks after surgery. So once you start physical therapy 4 weeks after surgery, you're still gonna be in your sling. You're restricted in your sling, still majority of the time, because the primary goal of this phase is to protect the shoulder and let it heal because it's still healing. You just went through a ton of trauma in the shoulder, so it needs its time to heal. But the primary goal of this phase, other than protecting the shoulder, is to achieve passive range of motion. The key word passive there being the physical therapist is doing the motion for you, and you're just relaxing and letting it happen. The active You also want to achieve active range of motion in the wrist and elbow, so you're actually achieving the motion. You're producing the motion there with active, and your elbow and your wrist. Like you didn't have surgery on elbow and wrist, but you have to move them and get them moving again because you've been stuck in a sling for that long. You're gonna get atrophy. Your wrist and elbow are gonna feel tight too. You've got to get the motion back in there. Phase 2. That's going to be 6 to 12 weeks after surgery. Goals to goals are to achieve full active range of motion. Um, so key where they're active and you want to actually be producing your entire motion yourself now. The phases that deal or the sorry, this phase deals with a lot of active range of motion while laying prone or supine. Uh, so they're trying to take as much gravity out of it as they can. And you can't take gravity completely out of it, but they can do their best job at it. The patient will begin to strengthen their rotator cuff muscles by doing internal and external rotations, such as this image here. Um, it's very common for a physical therapist to stick like a rolled up towel in between the elbow and the abdomen of the patient to reinforce that the patient doesn't abduct uh, while externally rotating. If they were to be abducting while they're externally rotating, they'd be turning on muscles that they don't want to turn on, such as the deltoid or the trap. Um, so yeah, phase three. Again, like I said earlier, patients must meet criteria of the previous phase before moving on. It's crucial that you don't rush a patient through the rehab process. This one typically begins about 10 weeks post surgery. Um, it varies for patients. The goals for this one is going to be to achieve full range of motion in all cardinal planes and normal rotator cuff strength. So exercises for this one's going to be internal and external rotation while in 90 degrees abduction, just like in this image here. You'll also be doing rowing and scapular stability exercises. Also, biking and running can start to begin. You're out of your sling at this point and kind of slowly go back to life as you knew it. So you can start to do activities such as biking and running. Phase four. Again, like I said, you got to meet phase three criteria before you go on to phase four. It typically starts at week 16. um, and then, so the goals for this one are going to be to get the patient to show stability in higher velocity movements while changing direction and normal rotator cuff strength with multiple reps, 90 degrees shoulder abduction. So, like in that image we had shown earlier. Uh, so, exercises are going to be you're going to want to educate the proper biomechanics of throwing again or whatever activity they're going back into, such as swimming or, like I said, shooting a free throw. It's all depending on what the athlete's going back into. That is what the biomechanics that they're going to be relearning. Um, the Say you have an athlete that has a labral tear and is throwing and had bad biomechanics before they had their tear or when they got their tear. When they come back, and if they were not taught proper biomechanics, they're gonna retear. They have more of a chance of retearing the labrum because they still have bad biomechanics. Maybe even worse biomechanics. But if you can teach them to have the correct biomechanics and to do the form and to do the activity correctly, you can possibly take some of the burden off of the labrum a little bit, and maybe keep the labrum from retearing. Many of the same exercises as in phase three, and you're also going to begin to incorporate trunk rotation. So phase five, again, you've got to meet steps from criteria four or from steps four, and usually this begins roughly around week 22. The goals are going to be to show stability with high velocity movements that resemble sport specific patterns. So again, are the biomechanics, and this is kind of when the throwing programs are going to begin, or the sport specific programs are going to begin, and this is when the athletes have that extra phase of stuff. You're also going to incorporate core and hip strengthening, because throwing doesn't only come from the arm; it comes from the core and the legs. exercises also for high velocity strengthening and dynamic control. And then, I just wanted to personally say thank you to Dr. Keene and Dr. McDaniel for making this internship an amazing experience. I've learned so much from Dr. McDaniel, and being able to kind of pick her brain, whether it be about a patient or about uh, any specific injuries or surgeries that we were seeing, or um, it's just been amazing to actually be able to pick her brain and learn from her. And I know that with the whole COVID-19 thing going on, it's been hard on both of y'all to actually make everything make normal. But I just wanted to say thank you and tell you that I appreciate that. All right, and then here are my references. All right, and that is everything. All right.